You're watching CTOM TV. Knowledge is power.
What I would love to hear about now, now that we've got a sense of how breast cancer forms in general, and that alpha and beta receptor that's important to understand. Tell us a little bit about how estrogen receptor positive breast cancer is usually treated these days.
Okay.
And I know even just saying usually treated, there are, well, there's a few hundred countries in the world, and there is lots of different approaches to treatment. There are some countries that are really on the ball in terms of using innovative options, and others who are still somewhat in the dark ages. We're going to talk about that as we go. But tell us how generally, if we're going to talk standard care in most industrialized nations, let's say that, okay, that's what we're talking about with standard care. How is it typically treated?
So typically what they do is they will look at the tumor and they'll look at the size of it. And then what they'll do is they'll do something called a sentinel lymph node biopsy. Once they've removed the initial tumor, they will do what's called a sentinel lymph node biopsy. And the sentinel lymph node are basically the lymph nodes that drain the tumor. They're the ones closest to it, and they're in line with the flow of the tumor. So the tumor, everything that travels through the lymphatic system that leaves the tumor goes through the sentinel lymph nodes. So they're the closest ones. The theory behind that is that if a tumor is going to metastasize, sorry, please my phone.
Siri, leave us alone. We're in the middle.
Siri, yes, I'm in the middle of something, Siri. Sorry. So typically what doctors will do after they do surgery is they will remove those sentinel lymph nodes, and they will look at them and see if there's any cancer in those particular sentinel lymph nodes. And if there are, then they're going to use that for staging and grading or staging to determine whether it's an early stage or later stage. What should really be done in that particular situation is a full body scan. It's not done commonly enough, and many times the doctors rely on a sentinel lymph node. So if you have had a breast cancer and your doctors are relying on a sentinel lymph node, book a private scan. You can do a whole body MRI. PET-CT is the best way to do it, but even a whole body MRI is a fairly cheap option for you, just to make sure that there's no other lumps in your body. And then if you do see a suspicious lump somewhere in your body and the MRI does not tell you what it is, then you can get a PET-CT. But definitely get a full body scan, and do not rely on a sentinel lymph node biopsy by itself to determine whether you have metastasis.
Oh, okay.
Well, because if you have metastasis elsewhere in the body, then it's a very different treatment protocol. Now, there's also something that we see quite a lot of lately, and these are called prognostic tests. And what they do is they look at a bunch of different markers in the breast cancer and determine whether chemotherapy is necessary. So definitely chemotherapy can be beneficial on a small early tumor prior to metastasis, but it does have issues. It has what we refer to as toxicity that can affect certain drugs like anthracyclines can cause heart damage and so on. So, there are concerns with getting a chemotherapy right away. So they do these prognostic score tests. There's a variety of different ones now to determine your risk. So if the tumor has spread beyond the local site, the breast tissue, for example, if it is in the lymph node biopsies, then they're more likely to do a scan, but not always. Then if it is elsewhere and you have what's called stage 4, where if the tumor is in a different organ, then it's considered stage 4. And then it's a very different treatment. Then we have a whole new protocol for treatments for that is quite effective. But let's go back to if it's just a localized tumor. Now it's going to occur in one of two different areas. It's going to be either in the ducts that deliver the milk, or it's going to be in the lobulars that produce the milk. And so these are two types of estrogen positive breast cancer called ductal or lobular. They're slightly different and they have different prognostic features. And we could get into the details of those a little later on, but they're both considered estrogen positive typically. They're usually estrogen positive. So once that is, let's say if a patient has a non-metastatic cancer, then they're given something called an aromatase inhibitor, or they're given tamoxifen. So an aromatase inhibitor, there's two different types of aromatase inhibitors. There's what we call steroidal and non-steroidal. And so the steroidal, an example of a steroidal aromatase inhibitor is called exemestane. And then the non-steroidal ones are called anastrozole and letrozole. So I'm sure everyone's heard of those. What aromatase inhibitors, they're known as AIs, what they do is they prevent your body from producing estrogen. So estrogen is produced through the aromatase pathway. And the aromatase pathway is basically an enzyme called aromatase that converts certain precursors into estrogen. Often it's androgens or testosterones or different molecules that it basically alters and converts them into estrogen. So when you inhibit that enzyme, you inhibit the body's ability to produce estrogen. However, the problem is that estrogen, this aromatase pathway can be active in a variety of different places. If, for example, a woman is under 50 and she hasn't reached menopause, then they'll often give a drug called tamoxifen. And tamoxifen is what we call an estrogen receptor binder. So it actually binds the estrogen receptors and plugs them up. And the problem with tamoxifen is it binds both, tamoxifen actually binds both receptors. It preferentially binds the alpha receptor. So it mostly binds the alpha receptor, but it also binds the beta receptor. And the beta receptor is important. You want to keep the beta receptor clear. So if there is any estrogen being produced, it's going to bind the beta receptor and it's going to cause those cells to stop growing. So when you use tamoxifen, while you are inhibiting the ability of estrogen to bind the alpha receptor, then you're also inhibiting the ability to stop that process too, by binding the beta receptor. Now, there's another issue with tamoxifen that is a bit of a problem, in reproductive tissues, you have the polar opposite effect of the receptors. So in, let's say, your uterus and your ovaries and so on, the beta receptor is actually the gas pedal and the alpha receptor is now the brake. So it's kind of an opposing function going on. There's a variety of reasons that our bodies do this. But the problem is when you use something like tamoxifen that binds both receptors, now it's going to start binding the alpha receptor, which is the brakes in reproductive tissue. And as a consequence, it can cause ovarian and reproductive cancers. So that's one of the negative side effects of tamoxifen. There's been some developments on that. There's actually a new drug it's actually been around for a while. We've been using it for quite some time, but it's a little more common in use now in Canada. It's called fulvestrant. And fulvestrant mostly just binds the alpha receptor. It doesn't really bind the beta receptor. So it's kind of like a new improved version of tamoxifen. So if a woman is diagnosed with a advanced metastatic breast cancer, then typically instead of trying to just inhibit the estrogen receptor through the aromatase pathway by reducing estrogen production, they just go straight to the receptor and you get fulvestrant, which is quite effective. Now there's another technology called Cdk46 inhibitors. And Cdk46 are two different pathways that are actually downstream. And when I say downstream, when you have the estrogen receptor and you have estrogen bind the receptor, it causes a signal cascade that goes through many different genetic features before it actually causes the cell to copy itself. So triggering of the estrogen receptor can lead up to thousands of different activated genes, or genes turned on and genes turned off. So it has many different functions inside of the cell to cause it to grow and copy. So it's not just a single pathway. There's many different pathways that offshoot. So the CDK4 and 6 pathways are two of those pathways that are very important in breast cancer. And so a class of drugs that inhibit those pathways are called Cdk46 inhibitors. And these have been a wonderful boost to treating estrogen-positive breast cancers. In fact, they're actually found to be beneficial in other types of breast cancers too, and we'll get into that a little later. So the very first drug was called Palbociclib. So these are called the Ciclibs. You've probably heard of these. So Palbociclib was invented about probably 5-6 years ago. We started using it. And it seems to work quite well, especially combined with fulvestrant. And so in that particular situation, when you get fulvestrant and Palbociclib, you get a much better inhibition of the estrogen alpha signaling pathway. And it's quite effective in metastatic breast cancers, shutting things right down. However, over the years, they found that there was a couple of key mutations. One of them is called a mutation in your RB gene, which is actually fairly common in estrogen-positive breast cancers. But there's a couple of other mutations in genes that can prevent Palbociclib from working properly. And so because of that, another company came along and said, oh, we're going to invent a version of Palbociclib that actually works against these mutations that stop Palbociclib from working. And so they invented ribociclib. And then, of course, after a little while, they found, oh, well, there's a couple of mutations in different genes that actually cause ribociclib from not working properly. So another company came along and said, we're going to invent a drug called abemaciclib. So you have your first generation, which is Palbo, you have your second generation, which is ribo, and your third generation, which is abemaciclib. So the reality of it is abemaciclib targets a bunch of other genes that palbociclib and ribociclib don't. So abemaciclib is pretty well the better drug to use. However, you don't necessarily need abemaciclib right off the bat. If you don't have certain genetic mutations, then palbociclib is just fine for you. Palbociclib is probably easier to access than abemaciclib. So these CDK4/6 inhibitors are really, really important, and they work very well with fulvestrant, which is what we call a selective estrogen receptor inhibitor.
Thank you for watching CTOM TV. Subscribe below and stay informed.